health justice. What do we want?
Health justice.
When do we want it?
Now.
Another world is?
Here and now.
Yes. Another world is?
Here and now.
Very good. Thank you, colleagues. Welcome to this side event. What makes universal health coverage truly inclusive? Advocating universal health coverage in Asian countries. This event is being organized by the GCAP Global Call to Action Against Poverty and our members and allies. As you know, GCAP works on issues of inequality and poverty for last about 20 years now, a little more than 20 years. And we are present in 66 countries across the world. We are closely working on sustainable development. We have been for the last 3 years working on issues of health and social protection. I am Pradeep Baisakh. I am the Asia coordinator of GCAP. We will have a long list of speakers, but we will definitely give an overview of several countries in Asia, including the region itself. Colleagues, as you know, during COVID time, we realized it before. During COVID time, we kind of saw the urgency of having a proper health care in place. COVID exposed the kind of weak health infrastructure and very fragile health services we have in the region, for that matter across the world. And we realized that not much has been done in this direction, and we actually need to do a lot on investing, creating good infrastructure, and also, getting access, enabling access of people into health services, which should mostly be public funded. From Kala Mata Declaration, health is declared as a human right, fundamental right, and an important social goal. And this vision has been taken forward by Sustainable Development Goal Agenda 2015. SDG 3 says about health and well-being. Despite all that, yes, due to SDGs, things have changed a little bit. There have been increase in government investment in health sector from 2019 to 2021. There are several areas which need further investment and serious attention by the government. Because of our less investment, inadequate investment in health sector, out of pocket expenses are too high for people, and which has pushed people into poverty, particularly the people who are the bottom 50%, they are suffering a lot. With this introduction, I would invite the first panel, Mr. Ingo Ritz, Director of GCAP, is here already. I invite Jeffrey is here, Jeffrey Akapa from APFSD, and Parag Pomke is here, Cooperation from Egypt, Cambodia, Becky Malay, Philippines Rural Reconstruction Movement, and Masaki, please come to the dais. Masaki Inaba from Africa, Japan, Core. So colleagues, because we have this is the first panel. After this panel, we will take a short question and answer session, and then we will come to the South Asians who will also present. We have long list of speakers, therefore I request all our eminent speakers to keep to 4 to 5 minutes. So we start with Mr. Ingo Ritz, International Cooperation for Achieving Universal Social Protection and Universal Health Coverage in Global South. So Ingo, what we need from the international community to strengthen the USP, Universal Social Protection, not only in Asia but across Global South. 4 minutes, 4 to 5 minutes.
Thank you, Pradeep. So, is that close enough?
It's not on.
It's not on. Hello? It's working. Oh, it needs to be that? Yeah, okay. I think now it's working. Good. So, 2015, the international community, the government actually, decided the SDGs and Agenda 2030, as all of you are aware. So especially the targets 1.3 on universal social protection and 3.8 on universal health coverage. So you know, generally we are off track with the SDGs, but in this, it's not working?
Yeah.
No, oh sorry. So according to the latest numbers of the International Labour Organization, only 52% of the global population has at least one access to one social protection, and even less to universal health coverage. So one can say this is really very bad for just 5 years before 2030. Because it's clearly written in the SDGs by 2030 all people should have access. So, I mean, as we are in Asia, and I feel like in Asia things are more is possible here and things can move faster in a way. I want to actually have a more positive and ambitious approach here. So looking back, at the financial crisis 2008, the global coverage on social protection was only 20% of the whole global population. And of course, in the rich countries, the coverage is almost 100%, around 90% to 100%. So basically, from 2008 to 2019, in only 11 years, the coverage increased a lot, up to 47%. So this shows how much is possible in actually only 11 years. With COVID, there was a bit of it got a bit slower, but anyway, another thought. I mean, I come from Germany, but let's say in Europe in general, this industrial revolution, there were many social problems, very similar also to many countries around the world. And the social protection systems were introduced, let's say generally towards the end of the 19th century. And what actually happened is that the social protection, which is this was demanded by the trade union and heavily fought for, of course. It's not, it didn't come just by from the governments. But what I want to say is actually, it's not that the rich countries are rich and they can afford social protection, but it's actually the other way around, that social protection also made the economic progress possible. And this is something I believe which is important, especially in Asia, to consider that the social protection is actually an enabler of development. And it is also, there's a strong multiplicator effect. So if you have social protection, it helps the economy. So I believe this is also an important factor for politicians. Another one is that politicians, that people actually like universal social protection and not small targeted approaches. So that one can clearly see in elections that universal approaches, which cover all the people, that means not only the poor but the middle class as well, are really liked by the voters. So this might be another strong argument in favor, because as you know, people can always fall back into poverty. So everybody needs protection, and especially for health. Everybody has at some point in life the need for health. For essential health services, and we can see what happens if there are no public systems. So let me come to the World Social Summit, which is actually happening this year in Qatar. And social protection will be a big topic, hopefully. So everybody, all the governments, civil society are in favor of social protection. That's good, but it seems like it's more on a very general level. My point is we need to have more concrete, more actionable ambitions. And actually, the idea and the proposal is to have national implementation plans to achieve social protection, including universal health coverage, which is actually part of social protection, in a certain time frame. So the implementation plans need to have also a financial part. So governments or needs to decide what is actually the time frame, whether it's 10 years, for example. And then it seems to be much easier. So if you, for example, introduce a pension scheme like in Nepal.
How can you wind up?
Yeah, so you can start with, for example, all the people above 70, and then you can go down maybe each year 1 year, for example. So in 10 years you are at 60. So there's no need to do everything at a time, and that's often difficult. So in terms of financing, the gap is 3.3% globally of GDP, and 2 percentage points of this 3.3 is for essential health services. So actually, as the time is over, just to make the point, I believe it would be really a big opportunity, the World Social Summit, to make this a global agreement, similar like the nationally determined contributions in the climate sector, to have nationally agreed implementation plans. So there are 3 elements. One, they need to be nationally developed and agreed and owned, of course. Second, there should be a financing element. So that means, of course, there needs to be support for part of the countries. Not all countries need this. But we need also to have progress, for example, on tax justice, that companies pay their taxes. So that's going a bit beyond, but there is a connection to the financing for development conference. And finally, what we propose is to have also regular review processes. So like in other processes every 5 years at UN level. So then it really becomes accountable, and governance needs to take it serious. So the first step, I think, is that civil society really owns this. Let me close. This is also one of the key elements to reduce inequalities. So not only to end poverty, but to reduce inequalities. And therefore, my point is really to make it, to make this a success, we need to become more concrete. And yeah, and as you said at the beginning, it's not only possible, but it is also needed. Thank you.
Thank you. Thank you, Ingo. So essentially you are saying that social protection is an enabler for economic development. Thank you. We will go to the next panel. Jeff, how far is Asia from achieving universal health coverage regime? 4 minutes for you. Please try to make it short.
I will.
So that everybody can speak.
Thanks, Pradeep. Good morning, everyone. So with regards to the state of UHC in Asia and the Pacific, when we look at SDG 3.8.1, the range of the differences in terms of how countries are progressing differ. You have countries like Thailand, China, Korea, and Japan who have more than 80% coverage, but at the same time you would have countries like Bangladesh and Laos PDR who have less than 50% coverage. But then while it is expected that countries who have less than 50% coverage would have percentage of populations that have household spending either greater than 10% of expenditures. Countries like Cambodia, for example, would have 16% of their population spending more than 10% on health. Same with India, whose 14% of their populations are spending more than 10% of health. You would have countries like China as well, even if they have 80% coverage. They have 16% of their populations are still spending out of pocket and catastrophic costs because of non-coverage. But when we look at the state of UHC in terms of covering key and vulnerable populations, so we're looking at LGBTIQ populations, people living with HIV, people who use drugs, sex workers, migrants, urban poor, people with disabilities, and ethnic minorities, and the list can be endless, different from one country to another. We conducted a survey in 2021 across 8 countries, covering Bhutan, Cambodia, India, Japan, Laos, PDR, Nepal, Pakistan, and Vietnam. And we look at some of these issues that some of the key and vulnerable populations experience when it comes to coverage. Number one is while the basic healthcare services are covered by the UHC in their countries, specific services are not covered. For example, harm reduction services for people who use drugs, even hormone therapies for transgender populations are not covered. Even as simple as medication for multi-drug resistant TB are not being covered by the UHC. The second is stigma and discrimination. So even if there are available basic health services, people living with HIV in Vietnam, for example, once they are found to be living with HIV, they are refused from the facilities to access these services. So even if they are covered, is the stigma and discrimination actually deter them from accessing these services. The third is of course physical access. The challenging geography in Nepal, for example, or the non-availability of the facilities themselves in many of the districts and provinces in Laos PDR is a cause also for non-access to these available UHC basic services. The fourth is bureaucracy and non-recognition of citizenship. This applies not only to informal migrants, but also those who are not recognized as citizens in their respective countries. And the last one is the systemic fragmentation of UHC system. So because of the disruptive, if not unclear policies with regards to centralizing information and data at the central level, every time a person living with HIV or every time a person with TB is referred from one district to another, they have to undergo a set of battery tests over and over, where they have to disclose their identities over and over. And this really causes a lot of dropouts in terms of enrollment with regards to accessing UHC services. So I think what we need to address really is to make sure that within the UHC, at least the available system at the country level, there is a recognition of these different populations. And how can we make UHC more person-centered? Recognizing not only a specific population, but also the diversity of the experiences and the needs that they need to access with regards to basic health care services, and specific ones as well. The next is two last points. The last is the overhauling of the system for health. So when we look at health systems, we also need to include community systems as well. There's already an established system, learning from HIV, for example, of how task shifting has actually helped expand the access to services not only within the facilities, but beyond the facilities. I guess my last point is we really need to prioritize health prevention. There was this discussion in SDG 3 breakout saying that we have to blame the private insurance systems for only covering treatment. Actually, it's not the issue of the private insurance. If the government insurance also covers prevention, there's no need for people to actually go to treatment if prevention is covered. And very last point, now that we're going into an era where in US and other Western European funding aid is retracting, I think we really have to rethink and reimagine how our UHC systems would be and how funded these should be, because these US and Western European funding is not sustainable. And we cannot rely on this development aid forever. So it's really time for Asia-Pacific countries and Global South countries in particular to really step up and fund our health.
Thank you, Jeff. Thank you. You're essentially saying this is a direct fallout of Trump closing down USAID That has made us realize that let us raise our own resources instead of depending on foreign sources. Thank you. Now I invite our colleague Prak Onkia from Cooperation Committee of Cambodia. Prak, what is the state of healthcare in Cambodia, and what issues marginalized communities face to access the services? 4 minutes, please.
Yes. Good morning, Excellency, esteemed partner and colleague. It is an honor to organize our event today at USPF. I would like to thank to USPF and GCAP for this opportunity. I am from Cambodian Civil Society Organization, especially the Cooperation Committee for Cambodia, and SP for all, we call social protection for all co-creation. And our area of work, we focus on analyzing the positive reading on law and policy, and also advocate for social protection, especially health coverage for marginalized group in Cambodia. There have been a significant achievement and progress in government commitment which were highlighted on national report and UN report by member states on universal health coverage. However, there remains a considerable gap between policy and implementation. So today I would like to share some key challenges that marginalized community face and accessing in universal health coverage in Cambodia. These challenges include: 1. Out of the pocket cost. Many people, especially from rural areas, struggle with their high in health expenses which consume a large portion of their income. This often prevents them from seeking necessary health care. 2. Limit health resources. Community health posts in rural areas are lack of basic medical and supply that medicine can make it difficult for people to access the care. 3. Distance to the health facility. Public district health posts are far from the marginalized people, and which is especially challenging for elder people and also pregnant women and indigenous community. 4. Shortage healthcare workers. Health workers are overwhelmed by large patterns, impacting the quality of care. In case of serious case, person has to travel a long distance from the rural area, or we call district areas, to the live hospital, public hospital at the national level. To address this issue, we propose following recommendations such as expanded health service by expand and extended social protection program to provide a free health service to marginalized groups. 2. Reduce out-of-pocket expense by strengthening the health system, good governance, transparency, and also reduce financial burden on marginalized community and also by individuals' expense. 3. Increase the national health budget by allocating more resources to improve the health facility, by medical supplier, and also build infrastructure. 4. Strengthening human resources by invest training, recruiting more healthcare workers, especially in under-serviced areas. 5. Supportive policy by adopting policy and law, regulation, and also strengthening implementation and also joint monitoring tools that align with UAC goal to ensure that health services are accessible to everyone and make sure that we are on track with Cambodia UAC roadmap. In conclusion, universal health coverage is not just a policy, but it is a human right. We must work together to ensure that everyone, especially marginalized groups, can access affordable and quality health care. With a collective effort of civil society, development partner, and all member states, we can achieve and make sure that UAC really for all and not just in Cambodia but across Asia. Thank you for your attention.
Thank you, Prak. So an outstanding Prak is pushing for more investment in health sector. She also raises that very vulnerable communities, groups like pregnant women, old people are facing issues of access to health coverage. Next speaker is Becky Malay from Philippines Rural Reconstruction Movement. Like we have heard that health system is working quite good in Philippines. If you can throw some light on that.
No.
4 minutes.
Short answer, no. But we have a universal healthcare law. It's anchored on the WHO's 3 pillars of the UHC, which are population coverage, service quality, financial risk protection. The law actually strives to ensure equitable access to healthcare across the country and institute governance reforms, which includes provisions to restructure the whole health system and improve service delivery and management. So the provisions of the law, all Filipinos are automatically enrolled in the PhilHealth's National Health Insurance Program, and membership has been actually simplified. Formal and informal members are either direct contributors, or if you are employed, then you can pay your premiums, or indirect contributors, meaning the government subsidizes your contributions. It's the government that pays for it, so you automatically get coverage. Number 2, the health system, the PhilHealth implements the National Health Insurance Program with the goal of affording Filipinos financial risk protection when they access health services. Under the PhilHealth system, members' contribution are 5% of their income shared by the employer and the employee to help cover the costs of the new law because it's been up. All Filipinos have access to preventative, promotive, curative, rehabilitative, and palliative care, with primary care services a priority. All Filipinos are guaranteed 0 co-payments for basic and ward accommodations and will pay a fixed co-payment for non-basic admissions in public hospitals. Co-payments and co-insurance are regulated. Number 6, performance-based incentive schemes are established for healthcare facilities. Number 7, health technology assessment and health impact assessment will be used to inform decision making. And then all public and private healthcare entities will be required to submit healthcare related and financial data and publish the prices of all health services and goods offered, meaning there's transparency supposedly. And the mechanisms will be established to monitor and evaluate the progress of programs, plans, and actions. So it sounds really good, right? But the implementation, the Philippine health system is actually highly devolved, meaning it's not centralized, and the relationship with the institutions responsible for providing healthcare services is segmented. The act implementation plan is primarily focused on reintegration, specifically with structural, managerial, and financial adjustments. Because it's not easy to devolve completely all the services that are needed for health provision. So there is now a proposal to divide the work between what is centralized and what is not. So access to medical products will be improved by establishing a health technology assessment council, which is in charge of the management of cost-effective, affordable, and quality medicines, supplies, and other medical equipment and articles. Provisions for the health workforce, which is a chronic deficiency, should be addressed by the National Human Resource Master Plan. So it seems like there's, a prescription for every implementation glitch that should happen. But the major areas of UHC implementation, shifts in the system of providing services can hardly be felt progressively for us in terms of realizing the right to health. Health is still a surrendered necessity when it comes to households, since it remains to be a financial burden despite the UHC. According to the Philippine Institute of Development Studies, every Filipino spent on an average 9,839.23 pesos for health-related goods and services in 2021, which is 17% higher than the 8,000 per capita health spending record in 2020. So it means it's just increasing, especially after COVID. So the challenges and gaps, we're looking at the fulfillment of the 45% per 10,000 population critical threshold recommended by the WHO for nurses, medical technologists, physical therapists, midwives, and other health workers. So we're still low on that, but in fact we're exporting nurses and health workers. So there's an irony there. Okay. While the law improves on the governance of field health itself by tightening the qualifications of field health officials, the financing reforms needed would require more transformative leadership, because after the fiasco of the 15 billion corruption issue during the COVID-19 pandemic, there is now a zero budget allocation for 2025 for the government contribution to the insurance scheme. So they have cancelled it totally. Zero subsidy for health. So it's, yes, that's 15 billion. It's supposed to be a law, but the lawmakers are defending the executive decision. So it is in fact they who actually cut it, and because they legislate, right? They cut it completely. So it's a Supreme Court case now. It's being tried in the Supreme Court because CSOs have actually fought it, filed a case against them. So there are significant cuts to the health facilities enhancement program, and GOCC hospitals are going to reduce investment sustainability in the health system. So we're looking at now issues of financing health, because not only did they cut, they also transferred the funds to somewhere else. So it is quite anomalous. Okay. So
Is that all, Becky?
no, not yet. Because
One more minute.
yeah, because I'm saying that these are program funds in the budget, and they have been moved to unprogrammed funds, and unprogrammed funds are not even audited. So this is a major setback for the health UHC, the Universal Healthcare Law that we have. So if we're looking at health, we look at the issues of universal coverage, but at the same time, the financing issues always come up, and this is a major issue because the unprogrammed funds that are now under the discretion of the president, and it's an election year, remember? So it is a patronage budget that we're having. So that kind of discretion that is being exercised by government officials now really have to be questioned, because it impacts not only from the out-of-pocket, on the out-of-pocket expenses of normal, people who need to access healthcare, but also from on the poorest of the poor who have been totally deprived of subsidies on health. Thank you.
Thank you, Becky. So despite having a robust policy on health, Philippines is facing problem of corruption, accessibility on. I invite our colleague Baisakh from Africa Japan Forum on universal health coverage and pandemic prevention, preparedness and response. So what are the correlation? And throw light some light on it. Baisakh, 4 minutes also for you. You are running actually out of time.
Okay, my name is Baisakh. I'm working as the chair of the Japan CSO Network of Global Health, which is a network of 30 Japanese CSOs working on global health. On this opportunity, I got the agenda of the BPPR, BPPR on the universal health coverage, but I mistook that I wrote the draft as the Japan's situation on the universal health coverage. So that on this opportunity, I'd like to introduce what happens in Japan, so-called one of the world's best social protection systems nowadays. It should be a lesson on what challenges on universal health coverage we will all face. The first, what happens in Japan, especially on the marginalized populations. Despite the drastic aging and the reduction of population that has been making our social protection systems weak and unsustainable, the systems have been working comparatively well to protect the majority of Japanese society. However, we have some key challenges on marginalization and vulnerability. First, migrants, especially who are undocumented or short-term stay are not covered by most of the social protection programs, including public health insurance. So their right to health has not been secured, neither emergency medical care nor treatment of chronic diseases. So many people fear high medical costs and go to hospital only when their illness gets worse. And secondly, elderly people with dementia. Japan has set up a long-term care insurance and a community-based comprehensive care system to guarantee care for people with dementia and elderly who require nursing care. However, the rapid aging and the decline of the population is hitting this system hard. While the population of facility users is growing rapidly, the number of care workers responsible for facility operation and care is insufficient. As a result, long-term care workers suffer from overtime and low wages. This has resulted in abuse and inadequate or inappropriate care in many facilities. Second, where the emphasis is on the inclusion of the people in vulnerable situations. There are several reasons why inclusion by the social security system is not adequate. One is persistent discriminatory prejudice. Japan has a public social security program that allows the poorest to access free health care. However, because of the intense persecution of the recipients of the scheme in the general society, many people do not want to receive benefits even if they are eligible. Another challenge is increasing tax and social security burden on the working age population due to rapid population decline and aging. Post-COVID-19 inflation and high prices have worsened the living standard of the middle class, and the dissatisfaction with high tax and social security payments is exploding. This has led to growing dissatisfaction with the redistribution of wealth itself, and Japan's social security system is in crisis. So third and finally, what are necessary as international solidarity. In Japan, the functioning of social security system has become fragile and unsustainable due to the population and the social structure changes. However, this is a challenge common to all the countries of the global north. As a result, the ODA function of the global social security has been weakened. In this context, what is needed?
Actually, 1 more minute for you.
Okay, I will finish soon. In this context, what is needed in the short term is protect multilateral health organizations such as the Global Fund to fight STD malaria from pressure to close or downsize and to support the WHO. In longer term, it is necessary to form and develop a financial mechanism based on global public investment in which everyone contributes and everyone can take advantage. So thank you very much.
Thank you, Masaki. We always think that in developed countries, the systems are very good. Here also we see that Japan is facing social security systems, challenges in social security systems. Thanks, Masaki. I'll open the floor for 1 or 2 questions, very brief or comments, and then we'll hear from the panelists. We'll have a second session, so we'll wrap it up as soon as possible. 1 or 2 comments, raise your hands, and then we reach out to you. Or there are mics there. Questions or comments?
Just wanted to ask, what's the trade-off between the universal health coverage vis-a-vis the quality of health services? I can count from my own example. Our universal health coverage is around 90%, but there is a deterioration in the quality of health services. So how do you balance that?
Okay, one more question. Give your introduction also, name and organization. Okay, in the interest of time, anyone from the panel would like to address this? UNC versus quality. Jeff, you want to start? Brief. You and Masaki can respond maybe.
That's actually a very good question because countries would usually define what's covered in terms of the services. And at the very least, there is a standard of what is being covered, basically the basic health services. But over the years, many facilities, including civil society organizations, have demanded that the quality of service needs to be also covered. But and this can translate into so many different variations and configurations. For example, training of using the funding from within the UHC structure to train health workers to improve the way they provide the services. It can also be the extent of the kind of medications, for example, treatment, and to an extent prevention services that are available and how they are provided. Extension of operating hours of different facilities can also be covered by UHCs. So UHCs not just basically provide covering for the medications and treatment of people. It also pays for an increase in the health workforce, increase in the number of operating hours of facilities, and the availability of health facilities and community-led responses who are extending the services from the health facilities into the communities. So UHC also covers those services as well. Thanks.
Thank you, Jeff. Half minute, 30 seconds.
Okay, well, this is a very difficult question, especially now. The privatization for the so-called good healthcare has been proceeding in many countries. So in Japan, the strong executive power of the public sector, government, is a key to standardize the services in public health. It is a key so that Japan was successful in the, I'll say, 10 or 20 years ago. But still, Japan, now Japan is very much, I'll say, got pressure on the privatization, and it is a very much difficult situation now.
Thanks, Masaki. I think this is something we heard throughout the APFSD meeting, private. As if private investment is key to all the successes. Probably people are closing their eyes. How much damage to human rights has been made by promoting private investment, which in most of the cases go unaccountable. Thank you. Sorry, we'll take the question next round. We'll wind it up. We'll have another round. So we'll wind it up here and let's give a round of applause to the So without any delay, colleagues, we go to the next session, which is on South Asia. I invite Mahanul Khan from Awas Foundation, Adrian Dickers from Molantolovia, Abhishek Shah from NGO Federation of Nepal, Abdul Awad from Noakhali Rural Development Society, Bangladesh, and Dr. Haita Vishwakarma, Asia Dalit Rights Forum. I also invite Jamila, if you can come to the dais, and then she will give the closing remark. We'll start from Mahanur. Mahanur, what is the state of healthcare in Pakistan? What are the issues that marginalized communities are facing? And we can also add a line on what our foundation is doing, and one or two recommendations. 4 minutes for you, Mahanur.
Good morning, everyone, esteemed panelists and participants. If we look at the current state of healthcare system in Pakistan, focusing on marginalized and vulnerable population, including women, PLWDs, and older people, despite Pakistan has a dual healthcare system with both private and public sectors, still inequitable access remains a major concern, with more than 50% of Pakistan population lack access to basic healthcare services. Women healthcare remains a highly inadequate. The maternity mortality rate is 186 per 100,000 live births, and Pakistan has the highest rate of breast cancer in Asia, with 40,000 women dying annually. PLWDs face severe exclusion, with 62% of men and 87% of women with disabilities, depending entirely on families for healthcare. Older people lack access to essential services, with 100% of surveyed elderly respondents stating that they do not receive any government social protection or health payments. Despite various policies, marginalized groups continue to face systemic barriers due to financial exclusion. As 66% of older people, 77% of women working in the informal sector lack access to any government health schemes. The second is geographic disparity. The rural area suffers the most, with limited hospitals, medical staff shortage, and inadequate infrastructure. Thirdly, the cultural and gender-based discrimination in Pakistan. Many women face mobility restrictions and cannot seek health care without their male permissions. Fourth, most public hospitals lack accessible infrastructure such as ramps and specialized health care services. Additionally, health spending in Pakistan remains critically low, with less than 2% of GDP allocated to health care, far below the recommended 5% by WHO. To address these challenges, we recommend a sustainable nationwide health insurance system must be introduced to ensure free healthcare access to marginalized communities. Increase targeted policies for women, PLWs, and older people, and allocate at least 5% of GDP to the healthcare. In this regard, the Awaz Foundation of Pakistan is actively implementing universal health protection by conducting surveys to assess people's access to social protection schemes, ensuring data-driven advocacy for marginalized communities. We have established healthcare desks to assist the individuals navigating available schemes. We're also empowering the women agriculture workers by advocating their labor rights and social protection through policy engagement. We work closely with the legislator to influence the formulation and implementing of inclusive social policies that safeguard the rights of vulnerable population across Pakistan. Lastly, I would like to highlight as an example the Sehat Solar program, which was a social protection program. It was a commendable initiative aimed at achieving universal health coverage in Pakistan. It successfully narrowed the equity gap, providing financial protection against catastrophic health expenditure for the low family's income. However, the program faced challenges due to the political transition, and many hospitals suspended the services over concerns that the new government might discontinue the program, as it was highly promoted by the previous administrations. So such situations underscores the need for the health initiatives to be insulated from the political changes. Healthcare programs should prioritize the well-being of the populace over political interest, ensuring sustainable and continuity regardless of the government transitions. Thank you.
Thank you, Mahendra. Very nice presentation and very crisp recommendations. If a scheme is doing good, it should not be changed by the subsequent government. That's the key recommendation coming from Mahendra. Thank you, Mahendra. Go to Adrian, give us a sense how things are going in India.
Yes, thank you, Pradeep. I am Adrian. I work at Vadana Toro Abhiyan. I'll just give you a quick current state of healthcare in India. In recent years, I'll start with a few positives because there have been a few positives in the past, say, 10 years. Life expectancy has increased drastically, as has births attended by medical personnel, trained medical personnel, which is a big problem in India. We have clear policy goals now since 2017, since a document called National Health Mission was established, focusing on primary health care and medical infrastructure and addressing particularly maternal and child health concerns. And despite high out-of-pocket expenses still in India, but it has seen a drastic decrease in the percentage in total health expenditure. From say 62% of total health expenditure was out-of-pocket expenses in 2014. Now in 2022, which was the last survey done, it was reduced to about 39%. So that's a big positive. Another positive is the world's largest publicly funded health insurance scheme, but anything in India is the world's largest because of the population. But the PM Jan Arogya Yojana, which is launched by the central government, it provides an annual coverage to every family who's registered to about 5 lakh rupees, which is quite adequate. It provides insurance to about 150 million families, which if you count the total number of families, it's about 69 to 70% of India. And it is also a portable scheme, so it takes care of migrants within the country, and it also allows for cashless treatment involving technological advancements. But now there are severe limitations, because if 70% is insured, that means 30%, which comes to about 400 million people in India, still live without insurance coverage. This is all according to government data. The insurance scheme excludes outpatient care unless you are admitted into the hospital for a particular procedure. You will not get any insurance. So outpatient care is a majority of out-of-pocket health expenses. The states bear a disproportionate financial burden. The national government is supposed to pay 60% and the state government is supposed to pay 40%. In actuality, state governments end up paying more than 75%, around 72 to 75% of costs of the scheme. And the government's own survey in 2023 of the scheme, it revealed a lot of systemic issues, infrastructure shortages, non-compliance and empanelment, inadequate oversight. Inadequate oversight is very important. Now, healthcare challenges in India also mean that there are many budgetary challenges. Only 1.94% of our GDP is health expenditure. 72% of all hospital beds in India, 72% of all hospital beds in India are in urban areas. And that is, that gives a picture of the inequity. Now, in terms of access for marginalized communities in universal healthcare, health expenditure has increased by about 88% since 2012. Almost doubled in the past 12-13 years. Even though the rural population has grown by 8%, the shortfall in rural health infrastructure has also grown by 6%. The health infrastructure has gone down. The National Health Policy, which I referred to earlier in 2017, it recommends a bed capacity of 2 beds per 1,000 persons. But according to government survey in 2021, India only has about 0.6 beds per 1,000 persons as of now. And one other startling statistic was that there's a structure called a community health center which serves about I think about 10 villages or so. It's a government health structure. It is required to have 4 kinds of specialists at all times: a surgeon, a physician, obstetrician, and pediatrician. As of 2022, only 10% of these rural healthcare centers had these specialists. Only 10%.
And then one more minute.
Yes. So my point about bringing out the healthcare system structure is that even though our government is funding a health insurance scheme, it has a way of making it unequal, unequitable. A lot of the government services are in the urban sector. Rural areas are definitely marginalized. Sub-centers, primary healthcare centers, where most diseases can be prevented, have seen a big decline in their growth rate since in the past decade. That was my point, that even though we are funding universal healthcare, we are going towards it, it is becoming more and more unequal.
Thanks, Adrian. Okay, so we are facing quite some challenges in rural areas of India, and that shows the inequality. Thank you. We will have other colleagues. We'll have Abhishek Shah from NGO Federation of Nepal. He could not make it. His flight was cancelled. So we have a video from him. Let me run it.
Namaste. I am Abhishek from Nepal and I work at NGO Federation of Nepal. Today I am going to share a few things about the state of health in Nepal. The history of modern and structured health system in Nepal is not too long. It is considered to have only for around 7 decades. A study conducted in 2024 has identified the total public health facilities in Nepal are 7,221. There has been many successful efforts in the health sector in Nepal. To name a few, a successful rollout of public health campaigns such as vaccination of polio, treatment of tuberculosis, and eradication of malaria are seen as a major achievement in the health sector. The government of Nepal has introduced the National Health Insurance Program in 2016, which complies with the Constitution of Nepal and works towards achieving the universal health coverage by 2030. This is a vital aspect in the SDG, especially for the Goal 3 and its target 3.8, universal health coverage. Another area of success is the awareness of mental health in the people, which is increasing, and people are opening up on this issue. They are no longer hiding in the mental health issues. The Nepal's constitution has ensured the right relating to health, which ensures that the right to basic free health services, right to get the information about his or her medical treatment, and equal access to the health services. Though the healthcare has substantially improved over time, yet disparity based on socio-economic status and location persists. There are challenges, especially for the marginalized communities, for better access to the healthcare. There are high political commitments, but weak translation of those commitments into action and practice. These commitments, this is the election manifesto, and the low and middle income people are taken as a vote bank, whose population is high. Also, the urban focused mindset of the politicians has sidelined the health issues of marginalized people, most of whom resides in the rural part of the country. As the marginalized community are not able to afford expensive healthcare, they experience compromised quality of healthcare and lack of urgent services when needed. Hence, the government should take strong actions against the corporate capture in the health sector in Nepal. We at NGO Federation of Nepal has done many interventions in the past, such as conducted several lobbies and advocacy meetings with the government to promote and strengthen the collaboration between the government and CSOs in the health area. We have conducted National Civil Society Conference for Summit of the Future, which demands the actionable plans and with accountability and stronger international commitment to support health sector. We have produced the 2024 Spotlight Vienna report, in which we discuss about the health system. We have raised awareness in the social protection area. We have conducted vaccine intervention for COVID-19, and also we have conducted National People's Assembly. A few recommendations for the government is to ensure accessible health facilities in rural and urban area. The federal system has given the decision-making authority on the development issues such as education and health at the local level. Hence, the local level government should prioritize to improve the infrastructure and provide quality services to its citizens in the health sector. The migration of the workforce in the health sector is increasing. The government should introduce practical and promising benefits package for them so that we can retain such human resources in the country. This is more needed, especially in the rural areas. Thank you.
Okay, there is Abhishek Sahab from Nepal. He was telling about the corporate capture of health sector in the country. Next we go to Abdul Awal from Bangladesh. He also could not make because he didn't get the visa. We'll run his video.
Friends and colleagues, in Asia we are passing through a crucial juncture for the SDGs that are supposed to be an inclusive healthcare system in all countries. In Bangladesh, despite of some progress, the achievement in UHC doesn't show a positive light that we are achieving within 2030. Bangladesh healthcare system is in a critical state due to lack of government prioritization and remain underfunded. Over the past 2 decades, we achieved good progress in improving various health indicators, including progresses in reduction of infant mortality rate, under-5 mortality rate, maternal mortality rate, etc. Despite these achievements, inequalities in access to healthcare services persist within the rural, disadvantaged and marginalized groups. Bangladesh is committed to achieving universal health coverage by 2030. To this end, we expect policy actions to increase fiscal space for health and expand coverage while improving service quality and availability. It needs public policy and funding that can ensure healthcare is a right, accessible to all citizens rather than a privilege to few. Key challenges are firstly, low public expenses, which limits its ability to provide UHC. Secondly, the high out-of-pocket spending that push people into poverty due to overpriced private services. And thirdly, equal access to services. Fourthly, the human resource challenges like shortage of doctors and health workers, especially in the villages and remote areas. We are advocating for actions to fulfill UHC by 2030. Citizens are demanding the urgent need for transition to a universal healthcare system that is equitable, accessible and financially sustainable has become now a pressing priority. And demanding for increasing fiscal space, government health budget allocation is less than 1% of GDP and only 5.2% of the overall national budget. This allocation remains stagnant at 0.74% of GDP. Such low spending on healthcare causes increased poverty, pushing families further into economic hardship. To expanding the coverage, the government should take actions to strengthen the primary healthcare system facilities by building more primary healthcare facilities, training for more healthcare workers, and making essential medicines and services more accessible and affordable by all. Lastly, improvement of service quality. We need more doctors, health workers to ensure that all remote centers and hospitals have adequate human resources. Finally, we would like to demand that APFSD should give urgent call to countries for fulfillment of commitment to achieve UHC and adequate public spending for health, and also take action to strengthening self-assessment by countries that ensure citizens' participation at all levels, and also civil society participation in assessment and also in emergency actions that we need. Thanks.
So that was Mr. Dev Awal from New Delhi Rural Development Society, Bangladesh. We'll have one more video, colleagues. Dr. Aita Vishwakarma will speak on Dalit, issues of Dalits in South Asia, insofar as health coverage is concerned. We'll run the video because his flight was cancelled, he couldn't come. After this, we'll open the floor. I'm mindful of the time also. Yeah.
And delegates from home and abroad, good morning and namaste. I'm Dr. Aita Vishwakarma, representing Asia Dalit Rights Forum. Asia Dalit Rights Forum covers 4 countries: Nepal, India, Bangladesh and Pakistan. The target community is Dalits in this country. It's my pleasure to present the health status of Dalits in South Asia at GCAP side event in Bangkok. Under GCAP project, we have conducted a research. So let me briefly highlight the welfare scheme under universal coverage, which has been found from the research. Yeah, first of all, let me talk about Bangladesh. In Bangladesh, maternity allowance scheme was researched, surveyed by Nagarik Udyog. So out of 100 household survey, so it has been found that 800 taka was provided to new mothers and expectant mothers. Yes, 82% of the mothers, they have awareness about the maternity allowance. 59% of the mothers, they have ideas about the application procedure, and only 45% of them applied for the maternity allowance. So interestingly, only 33% of the respondents received that maternity allowance. Regarding Nepal, enrollment was was very scheme that has been researched. Yes, the total population in Nepal is 13.6% in Nepal. Equity Society Nepal carried out a research study. It was found that 23% of total population have enrolled in health insurance in the national level. Whereas in the case of Dalits, only 17% Dalits have enrolled in health insurance. Among them, 10% were male and only 7.6% were female. That means there was a visible gender disparity in the health insurance enrollment in Nepal. In India, that's 16% people are Dalits, and the NCDHR has carried out a survey study. The government of India initiated Ayushman Bharat insurance program. In this program, this is the government initiative to achieve universal health coverage. The study showed that 70% of the states were aware of the scheme. Yeah, and 500 million people are provided health services, through this scheme. In Pakistan, especially Pakistan Dalit Solidarity Network, PDSN, carried out a research. It's all about senior citizens allowance. 200 rupees provided to senior citizens and elderly women to live a dignified life. Yeah, overall, whatever happens is this, Dalits face exclusion in these welfare schemes. There is a discrimination and there is lack of resources and accessibility to these communities. As a intervention, what we have to do is substantial funding is required to support these Dalits with welfare scheme to be effective health coverage. Thank you.
Thank you, Dr. Aita. We're running out of time and in fact have run out of time. So I'll request one intervention maybe, the girl, and one, two. Okay. Then you three. Very pressing.
Thank you for the opportunity and thank you for the wonderful and insightful presentations. So my name is Lucia. I'm from Indonesia, represent MCS, International Movement of Catholic Students and International Youth Training Center. So my question is, how we can ensure that all the recommendations and all the initiatives for the universal health coverage in Asian countries, not just policy commitments, but truly impactful and meaningful for marginalized communities such as indigenous people, rural population, and informal workers. So yeah, we already see that some recommendation initiatives that each country had already presented. So thank you.
Thank you. Okay, you can go next.
Hello, I'm Jia. I work in the Research Institute under Chulalongkorn University and WHO Regional Office. Previously, I worked on health policy in Singapore. So I just want to make a quick comment, especially on the gaps in rural areas. I believe in Thailand what they do is that they provide scholarships for the medical students, following which they have to work, 3 years in the rural areas, especially in their hometowns, so they're also inclined to stay there, because I think the gap is always an issue in most countries. My question is on migrants actually, because it was surfaced a couple of times, and I'm quite interested in the advocacy or what you all find might be effective, because I think it's quite a difficult issue, especially when they lack the citizenship in the countries that they are in. Thank you.
Thank you, Sandra.
This is Sangat. I am representing Empower India. It's a civil society organization based in India. I am representing the older people because I am mentioning about the older people. The older people who have been a high need for health and health services often struggle to access them. Older people also face additional barriers to the right to health, including issues of availability, accessibility, acceptability, etc. So universal health coverage is a key focus area in the coming second World Summit on Social Development this year. Cannot be achieved without addressing the needs and rights of the growing older people populations especially in these rapidly aging regions. So this is our request on behalf of older people. We call on governments and health sectors at all levels to scale up public investment in urban health coverage and universal health coverage, and to champion age and disability inclusive and gender responsive. Thank you.
Thanks. Yeah, please. Maria.
So this is Maria Pasha from Wider Asia Pacific, and I'm delegate of APFSD Youth Forum 2025. So my question is related to the youth, because as we discussed the financing element and nationally aggregated system with respect to the UHC. So what as a youth can we do? What are your recommendations? What are your call to action for youth to work on this issue? Yeah.
Thanks. We 30 seconds for Adrian and 30 seconds for Magnus.
Okay. To address these questions, I have this one comment that as we have heard all these presentation from the Asia side, we have observed that it's not the first privatization of the government towards achieving the universal health coverage. As privatization is not a solution. So I believe that the government should revisit and prioritize universal health coverage to ensure, as it becomes the social responsibility of the state to ensure these facilities to their people. It's not about the private sectors who will come and intervene to provide these services to the people. So I would just recommend and for the youth perspective as well as to advocate and do the lobbying with the policies through media campaigns to urge the government to make it their privatization instead of investing in the infrastructure projects, making the roads and all. Because in Pakistan we have observed that the government's interest is to rebuild and reconstruct the buildings and the roads. It's not going to uplift the nation as a whole.
Right.
So that's
Sorry, Madhu. Thank you.
Yes, thank you for your question. I think first and the last question are similar in terms of what should the youth and say civil society organizations, youth from civil society organizations can do. I think, of course, advocacy is a key part of what we do, but we have to be and we must change the course of our advocacy, the nature of our advocacy. I think since as youth members we have what we call energy and passion and all this, so I think we should channel this energy into actually evidence-based research at the ground to bring out more stories from the ground, stories of exclusion, actual surveys that show the inadequacy of health in terms of marginalized communities' access to it. These stories, these things can be used in campaigns. These stories have weight that policymakers can actually listen to. So rather than just banging on the heads of policymakers saying that you're not doing enough, you're not doing enough, show them how they are not doing enough. Actually, evidence-based research, which is what we have been trying to do for the past few years in terms of citizen-generated data and people-run campaigns.
Yeah, thank you. So thanks the panel. Now I mean for that let's give a round of applause to the panel. I invite our friend and colleague Jamila Ashtanova from Asia Development Alliance to do the closing remarks and thank you.
Thank you. Good morning, everyone. Thanks for organizing such important event with this topic, because it's related for sure with SDG3, which is on the agenda of the of this forum. And if we will look to this, all partnership, congratulations, Pradeep, you collected a count of 13 different logos, and the ADA from your side on the right corner is one of the partnering. So, and I think that the health is usually universal thing which we have to not only think but also to do, and I am totally support what Ingo mentioned in the beginning, that we are practitioners, we have to support as a civil society, we have to have more concrete actions, more steps. So, and on behalf of this one, I am encouraging civil society be more proactive, because yes, governments are trying to be responsible because health, it's one of the common issue for all population, for all generation. In this case, first, I would like to mention about the intergenerational cooperation. Because, for example, in some countries, I don't know, like kids, when they are born, you know, it's vaccination issues, mandatory, you know, but some anti-vaccination, you know, that these issues which couldn't be done, you know. I think it's something which we have more senior people and you know, connectivity with just younger generation. It's important first. Secondly, and according to content, I think more important to work with corporations, and maybe you know, if we come to corporations, they say, oh, we're providing, for example, in our country 20%, and according to their high-level contract with the government, we're putting 20% of our incomes to the government. That's it, and they will deliver through local authorities or through governments on the local level. But we are, as a civil society, we need to talk with the local government, hey, and to monitor this kind of issues. How the local communities, when you are getting gas and oil or other natural resources, how there's money which corporation already provided to government, how you will get, how you will distribute to the communities. And for example, there are a lot of cases when the community-based organizations or local citizens, they are encouraging with local governments to integrate their needs, their social requirements to the local government. Such kind of dialogues need to be done by the civil society. And what I would like to say third, it's some advocacy on a global level. Yes, the SDG 3 is under the agenda of these VNRs in this year. And we in some countries already someone mentioned about the people's scorecard. In the parallel research with civil society are getting how the SDGs are achieved by the opinion of civil society. So, and we are collecting this data, and I think it's for us it's also one of the opportunity to provide communities' voice on high-level political forum and raise this question again. Congratulations, Pradeep. It's very good, productive session. I think there are a lot of people into the forum. Thank you.
Thank you. Thank you, Jamila. Thanks, Pradeep. Thanks, Pradeep. Thanks, speakers. Thanks for the staff. We close the session here. We have tea and snacks outside. Please have it. We'll keep in touch. Thank you very much. Okay, can you come here for a group photo? Quickly. Yeah, thanks.